I will be talking about the antibiotic and the mechanism of action of each antibiotics. So, talking about the antibiotics, first I will classify the antibiotics. So, we have cell wall synthesis. So, we can inhibit the synthesis of cell wall in a bacteria. This is one group. There is another group. We can inhibit the protein synthesis. So we can inhibit the protein synthesis. The third group include the bacteria which is aimed at attacking on the cell membrane, and we have another class that is DNA gyrase inhibitors, and the fifth class that is antifolate antibiotic. Antifolate antibiotic. So we need to know whether which one is bactericidal, that will kill the bacteria, and which one is bacteriostatic. Suppose this is the bacteria, the cell membrane of the bacteria, and it is having a cell wall. So when the antibiotic act on the cell wall and disrupt and inhibit the synthesis of the cell wall, the sodium and water that will enter into the bacteria, and the bacteria will swell, and there will be cell lysis. So this cell wall synthesis inhibitor, it will kill the bacteria. So it is bactericidal. Whereas the cell membrane inhibitors, so they, by disrupting the plasma membrane, the contents leaks out. So it will also kill the bacteria. That is, it is bactericidal. Bactericidal. Now about the protein synthesis inhibitors. By inhibiting the synthesis of protein, they are bacteriostatic, but there are certain exceptions such as aminoglycoside. So this aminoglycoside will kill the bacteria. So it is bactericidal in effect. Now about the DNA gyrase inhibitor. So this DNA gyrase inhibitor, as it is involving the DNA, this is also bactericidal. It will kill the bacteria. About the antifolates antibiotic, this is bacteriostatic. It inhibits the growth of bacteria, but there is an exception, that is cotrimoxazole. So this cotrimoxazole, it will kill the bacteria. So it is bactericidal. Now I am gonna explain about, to understand about the cell wall synthesis inhibitors, we must know that how the cell wall is synthesized in the bacteria. So basically the cell wall of the bacteria is made up of peptidoglycan. So that it has a peptide part as well as a glycan part. that is glycosaminoglycan. So if this is the cell membrane of the bacteria, here we are having N-acetyl glucosamine. So this N-acetyl glucosamine, it will be converted into N-acetyl muramic acid by the addition of phosphoenol pyruvate in the presence of an enzyme enol pyruvate transferase. So N-acetyl muramic acid is formed here. So this N-acetyl muramic acid as well as N-acetyl glucosamine, it gets incorporated. So this complex is called as the glycosaminoglycan complex. So the glycan part is synthesized. Now the peptide part, there is L-alanine that is converted into D-alanine with the help of an enzyme that is alanine racemase. So this D-alanine, it will be a peptide chain is formed with the help of the enzyme alanine ligase. So this is the peptide chain that is formed, and there is addition of glycine also. So there is addition of glycine. So this together we can call it as, that is glycosaminoglycans plus this peptide chain, we can call it as, that is a 1 unit of cell wall. So that is 1 unit of cell wall, and this 1 unit of cell wall, it is transported outside the cell membrane. So here you can see this is a cell membrane by a transporter. This is a lipid transporter. Lipid transporter named bactoprenol. So by a lipid transporter bactoprenol, this 1 unit of cell wall, it is transported out to synthesize the cell wall, because the cell wall is present outside the cell membrane. So here we are having 1 unit of cell wall, and so the cell wall are formed by cross-linking of many units. That is, so here we are having 1 unit of glycosaminoglycans that is joined with the peptide, and we have the glycine. Another unit of the cell wall, glycosaminoglycan, that is joined with glycine. So the cross-linking happens between the D-alanine of 1 unit, you can see the D-alanine of 1 unit and the glycine of another unit. So this is a D-alanine of 1 unit and the glycine of another unit. Similarly, the other units get joined, get cross-linked with the help of an enzyme that is transmembrane peptidase. So with the help of this enzyme, the cell wall are synthesized. So this is how the cell wall is synthesized. Now it will be more easy to know how the various drugs act. So we have a drug that is called phosphomycin. Phospho, phosphomycin and phosmidomycin. Phosmidomycin. So these two, you can see that it is similar to the name of phosphoenol pyruvate. So this will act as an analog of phosphoenol pyruvate, and it competitively inhibits this enol pyruvate transferase enzyme. There is another group that is called as the cycloserine. So these drug cycloserine, it is an analog of this D-alanine. It is an analog of this D-alanine, and it competitively block this alanine ligase as well as the alanine racemase. So these two enzymes are blocked. So there is no synthesis of the peptide chain. So there is no synthesis of the cell wall. Now there is a drug which is called as bacitracin. So this bacitracin, it inhibits this bactoprenol, so that it blocks the transport of the unit of cell, that is the cell wall unit, outside the cell membrane. There is another drug which is called as vancomycin, and this vancomycin, so this vancomycin, it will be blocking this D-alanine. So the D-alanine is blocked. So therefore the cross-linking is blocked, because the cross-linking happens between the D-alanine and the glycine. So that cross-linking is blocked. Now, so this is an indirect blocking of this cross-linking. Now there is another drug that is called the beta-lactams, penicillin, cephalosporin, monobactam, carbapinam. Penicillin, cephalosporin, monobactams, carbapinam. So these beta-lactam, it go and inhibit this, block the transpeptidase enzyme, so that they directly go and block the cross-linking. So the cell wall synthesis is blocked. So this is how the various drug is acting. So now I will be going into detail of these drugs. I will be only highlighting the important points regarding these drugs. So about phosphomycin and phosmidomycin. So I have said that this is a PEP analog. So they competitively inhibit this enol pyruvate transferase. So this drug, they will enter the bacterial cell by glucose 6-phosphate transporter. Suppose this is a gram negative bacteria. So this is a gram negative organism. So this glucose 6-phosphate transporter, glucose 6-phosphate transporter is present in the gram negative organism. So this drug will enter the bacterial cell of gram-negative organism. Moreover, this drug is well concentrated in urine. So there is an advantage. The advantage is that because it is more excreted by kidneys, this drug will be well concentrated in urine. So this can be used to treat urinary tract infections. And this drug, that is fosfomycin and fosmidomycin, it is safe in pregnancy. So during pregnancy, the chance of urinary tract infection are high. So we can give fosfomycin, and the dose is 3 gram single dose fosfomycin is given. More commonly used is the fosfomycin. Now about the next drug, that is a cycloserine. So I have said that it is a D-alanine analog, and it competitively block the alanine racemase and alanine ligase. So the spectrum is limited to gram negative bacteria, and it is used as a second line drug in TB. Second line drug in TB. It is not that commonly used. It is because of its side effects. It is having neuropsychiatric side effects such as seizure, psychosis, peripheral neuropathy. So, such side effects are common with cycloserine. Now, another group of drug I'll be discussing is about the bacitracin. So, the bacitracin inhibits the bactoprenol, that is, it will block the transport of the unit of cell wall outside the cell membrane. But this is also having side effects. It is nephrotoxic and it suppresses the bone marrow. So due to this action, it is used as a topical drug. It is not used as a systemic drug. So it is used as a topical drug. It is FDA approved. So to treat bacterial skin infection, then staphylococcal nasal carrier. But the drug of choice for staphylococcal nasal carrier, the drug of choice is topical mupirocin. So this is the drug of choice, but bacitracin can also be used. So it may be given, we can also give the bacitracin orally for localized GIT effect, because this drug, when you take, it is not absorbed in your body. So if there is a localized GIT effects such as the enterococcus and the pseudomembranous enterocolitis. So to treat, so these are the problems of colon. So we have to, it is a localized GIT effect. To treat that, we can use bacitracin. So now about the vancomycin. So this vancomycin is a glycopeptide. From the name itself, we can see they are peptides. That means they are proteins. These drugs are larger in size. So that means they are having poor oral absorption, and the spectrum it is limited to gram positive bacteria. It is because we have a gram positive bacteria as well as a gram negative bacteria. Actually, the thickness of the gram positive bacteria, the thickness of the peptidoglycan layer, it is more in gram positive bacteria. But still, in the gram negative bacteria, so if this is a gram negative bacteria, to actually it is tightly packed and there are porins. If this is a gram negative bacteria, there are porins. So only through the porins it can enter. Actually, outer to the cell wall of the gram negative bacteria, there is a lipid layer and there are porins. Porins. So only through the porins the molecules enter. So to enter a gram negative cell, the antibiotic should be smaller in size as well as water soluble. So the peptide, as it is larger in size, it cannot enter through the porins. So the spectrum it is acting, it is limited to the gram positive bacteria. In case of MRSA, that is methicillin resistant Staph aureus, IV vancomycin, intravenous vancomycin, this is the drug of choice for MRSA as well as you can use for Enterococcus faecium. Enterococcus faecium. So the drug of choice is intravenous vancomycin. Then we can use the oral vancomycin as the drug of choice for pseudomembranous enterocolitis. So this is for localized effect. Actually, the vancomycin is a glycopeptide, so it won't be absorbed. So in the pseudomembranous enterocolitis, it is a problem of the GI tract. So for the localized effect, we can give oral vancomycin as a drug of choice. The prophylaxis for the pseudomembranous enterocolitis, we can give an basilotoxumab. So basilotoxumab. So the name of the drug itself indicate it is against a toxin and it is a monoclonal antibody, that is anti-clostridium difficile. So this is anti-clostridium difficile, toxin B antibody. So it is actually caused by the antibiotics. So we are having a normal flora, and due to the use of antibiotics, there is the overgrowth of this Clostridium difficile organism. So the most common cause is due to the third generation cephalosporin. This is the most common antibiotic that we use. So there is excessive growth of this Clostridium difficile, followed by aminopenicillin, followed by the fluoroquinolone and clindamycin. So the more commonly used drug are the third generation cephalosporin, aminopenicillin. So that is why they are indicated in the more common antibiotics, which is responsible for the excessive growth of the Clostridium difficile. So now what are the side effects of this vancomycin? Next, about the side effect of the vancomycin. So there is actually increase in the level of histamine. So due to increase in histamine, there is actually flushing of blood and there is appearance of redness. And this is called as Redman syndrome. Redman syndrome. Then this vancomycin, it is actually nephrotoxic as well as ototoxic. It is toxic to the, it is nephrotoxic as well as ototoxic. So there are other glycopeptides are, that is teicoplanin, then dalbavancin, then telavancin and oritavancin. So this dalbavancin, it is actually the longest acting glycopeptide, and this telavancin and oritavancin, they are the most cidal glycopeptide. It is because they can also disrupt the cell membrane. They can disrupt the cell membrane. So these are FDA approved for MRSA infection of the skin and soft tissue. MRSA infection of skin and soft tissue. So it is the skin and soft tissue, it is applied locally. It is not used as systemic drug. So that is about the vancomycin.